Bismillah ar-Rahman ar-Rahim. Chronic lung disease of prematurity. Formerly and still in the United States of America, known as bronchopulmonary dysplasia, BPD, advances in neonatal medicine have led to improved survival of premature babies with immature lungs and respiratory disease. Babies born at lower gestational ages are surviving into adulthood due to therapy with antenatal steroids to prevent respiratory distress syndrome and the use of artificial surfactant to decrease the surface tension of the neonatal alveolar membrane. There have also been improvements in ventilatory techniques, and chronic lung disease of prematurity (CLD) usually occurs in babies who have been mechanically ventilated. Most long-term studies have been on patients before this improvement is in management. The usual causes of chronic lung disease of prematurity or bronchopulmonary dysplasia are the following: volutrauma from prolonged mechanical ventilation, high pressure ventilation, ventilation with high O2 concentrations. The typical presentation of CLD include the following: the premature babies remaining O2 dependent after 36 weeks post-conceptional age, infrequent in those born at 32 plus weeks and weighing more than 1 kilogram point 500 gram, may require prolonged home oxygen therapy up to 1 year or beyond. 50% of infants will need hospital readmission during their first year with respiratory infection. Some have significant pulmonary sequelae during childhood and adolescence. Airway hyperactivity persistent with chronic hypoxemia and pulmonary hypertension are, are usual manifestations of CLD. Duration of autodependence predicts long-term sequelae. The patient of the infant of CLD may have additional disabilities associated with prematurity, such as cerebral palsy or learning difficulties. The pathology of CLD or chronic lung disease of prematurity include the following: cytokine mediated scarring and repair, early inflammatory phase, which include bronchial necrosis, alveolar destruction, capillary permeability, and associated obstructive bronchiolitis, subacute fibroproliferative phase, type 2 pneumocyte hyperplasia, bronchial and bronchial smooth muscle hypertrophy and interstitial and perialveolar fibrosis, chronic fibroproliferative phase, including airway remodeling for up to 1 year and bronchial wall thickening. Prior to surfactant use, these changes were more severe. Pulmonary function tests in chronic lung disease of prematurity or bronchopulmonary dysplasia. The function and respiratory abnormalities persist with increased airway resistance and airway hyperresponsiveness. Residual volume and residual volume over total lung capacity ratio are raised, indicative of air trapping. Air trapping improves over 3 to 4 years as lung growth occurs. However, small airway abnormalities persist at least until the age of 10 years. A cohort will not achieve expected normal lung volumes and therefore may have fixed airway obstruction and chronic obstruction or chronic obstructive pulmonary disease in adult life without accelerated lung function decline or smoking. Expired nitrous oxide levels are usually not raised, indicating a non-eosinophilic driving process, a non-eosinophilic driving process. A chest radiograph in CLD or bronchopulmonary dysplasia, there is persistent mild to moderate abnormalities, and there are multifocal areas of reduced lung attenuation and perfusion, bronchial wall thickening, and decreased bronchus and pulmonary artery diameter ratios on computed tomography. Radiological abnormalities correlate with histological evidence of air trapping. Pulmonary hypertension occurs commonly when persistent lung disease, complex pathophysiological factors, and it tends to improve with age. In adulthood, few longitudinal studies beyond adolescence and longitudinal studies show airflow obstruction without eosinophilia. Common high resolution computed tomography HRCT findings include subpleural opacities and expiratory gas trapping, but not emphysematous changes. It is likely that individuals, even without smoking, will have significant fixed airflow obstruction in later adult life, similar to individuals with COPD. There are no evidence based consensus guidelines for management and individual disease traits such as fixed and variable airflow obstruction, airway inflammation, and hypoxemia should be considered and treated as appropriate. That is all about chronic lung disease of prematurity or bronchopulmonary dysplasia. Thank you.